Hey everyone, thank you so much for joining us today. We're just going to give it 5 more seconds to let everyone come in from the waiting room, and then we're going to get started. Okay, so again, thanks so much for joining us. I'm Judy Krasna. I'm the Executive Director of FE.A.S.T, and I'm thrilled to welcome you all to today's webinar. The topic is When FBT Alone May Not Be Enough, Adding DBT into Treatment. And this is probably both my favorite topic and my favorite speaker. So it's a really good day for me, and I know it's going to be a really good day for you, and you're going to learn a lot. I just want to remind everyone that your cameras and microphones are currently off, and we request that you keep them off through the duration of the webinar. And if you have questions, and please do have questions, you can use the chat box in Zoom and just stick your questions in there. And at the end of the webinar, there will be time for you all to ask your questions and to have them answered. And the question that I know you're going to ask is, will Lucine share her slides? And the answer is yes. So no need to ask that. I've just answered it for you. She is kind and generous and sharing her slides, and I know that's going to really help a lot of people too. I just want to say something personal about this topic. I taught myself DBT at a point where I realized that, we needed something else. And I didn't really know what that something else was, but the treatment that we had for my daughter wasn't working. And I went online and I started researching, and I found DBT on my own. And I started watching these YouTube videos, Marshall Linehan and a lot of other people. And it really, really gave me, it wasn't just a language. It was like, it allowed me to wrap my head around so many things that I found so confusing, and to actually gain skills that helped me care for my daughter. And I firmly believe that no parent ever, ever, ever should have to do what I did. No parent ever should have to be on their own searching for skills and for information that's going to help them help their kid. So it's very important for me to bring this topic to you all at FE.A.S.T, and I really hope that you get a lot out of this webinar. Thank you so much, Lucine, for being here with us. And now I'm going to hand it over to you.
So I can share my screen now?
Yes.
Okay. Now let's see if I can pull it off, because, as I was sitting here, okay, we're going to do this. No, wait, that's not the right one. Share that. All right, fabulous. Well, thank you so much, Judy. And thank you, as always, for inviting me, for such a warm welcome, and for, sort of bringing your own experience into this topic where, I think that so many parents benefit by and that's what FE.A.S.T is all about, from hearing about from other people who have been through what you've been through, and being able to learn what works and what doesn't. So again, thank you so much.
I just want to point out that you're not on a slideshow view, so you probably want to just fix that.
Oh, see, you know what? See, this is what happens. I have two screens, and so I apologize. Let me just go back to stop sharing. So sorry. And I will go back here. Let's see if that works now. Is that working?
Yeah, just put it in slideshow. Yeah, now you got it.
All right, fabulous. All right. So, this is a fascinating topic, and I was very appreciative of the request to speak, because then it gives me the opportunity to think through, what do I think? And I am a research-oriented psychologist. I have a clinical psychology degree, which means I have a PhD, which means I did extensive research. I did a postdoctoral fellowship. I am very invested in what the research says is effective, which is what you see here on this slide: a guide to selecting evidence-based psychological therapies, which is where I want to start. And this was something that I was invited to do by the Academy for Eating Disorders, which is the premier professional organization for those of us who work with eating disorder clients. And this is something that we did during COVID, where we were asked, and with a group of international experts, to review the literature from different countries to talk about, like, okay, what is an evidence-based psychological treatment? Now, I'm going to start with that because, again, that's how I think about treatment in general, is you start with the evidence, but unfortunately, the evidence doesn't always work. So if we look at a pretty recent article that was published out of Denmark. And don't worry, I'm not going to be talking about research the whole time, but I do want to start there again, so we're all on the same page, that an evaluation of using FBT for patients with anorexia in kind of more real world environment, so sort of in their public health system rather than in a controlled research study. And really only about half of people respond to it. As a field, we need to do better in terms of the treatments that we have. And so although I start with research, because again, that's my background and that's my experience, I'm a clinician. I treat a lot of patients and I see firsthand that it's not enough or it is not the right treatment, even though I might start with the research. And I think that, it's important for us to remember, and I think, when I look at who's on this webinar, I see that there are families, but I also see professionals. So I think it's important for us all to remember that the evidence-based approaches don't always help, or they may not be enough. And I use this image of penicillin to remind us all that, if someone has an infection and they're prescribed penicillin, although it's probably a bad example now because no one gets penicillin as a first line treatment, but let's say you did and it didn't work, you wouldn't say, oh gosh, you didn't want to get better. You must not have really wanted recovery from your infection because you didn't get better. We would say, oh gosh, the penicillin didn't work. Did we give them the right medicine in the first place, or do we have to add to it? And I'm hoping that with my talk today, we can think about treatment for eating disorders in the same way. So I don't know why that happened, but that's okay. So they're supposed to say, here we go. Are there predictors that tell us that FBT might not be enough or not the right treatment? So what do we know from research about, gosh, if you're experiencing if you're working with somebody and you're finding out that your kid is not getting better, is there something in research that would help us know, yeah, you have the kind of family member that might not have responded to this treatment in the first place? So we know that, let's start with who does well with FBT, early onset, short duration of illness, which frankly is the truth for most medical issues or most psychological issues. If you haven't been ill very long, it's easier to turn the boat around, right? Early and having an early response to treatment, and we call that the 4 and 4 response. If they needed to gain weight and gain 4 pounds in 4 weeks. So those are the people who generally do well in FBT or who are more likely to do well. Those who are might be at risk for a poorer outcome are people who have a high level of eating disorder symptoms and have comorbidities, meaning they don't just have an eating disorder, they have an eating disorder plus depression, plus anxiety, plus substance use. So the more, and again, this makes intellectual sense because if you have more problems, a single treatment may not be enough. A parent history of psychiatric illness is a poorer outcome. And we're going to talk about that. And in no way, I want to give you a public health service announcement. In no way do I think that that means that the parents caused the kid's eating disorder or that it's the parents' fault that things are not getting better. But if you have your own psychological problems, dealing with your kid's psychological problems may be extra difficult for you. If your child has emotion regulation deficits, if they have a diagnosis of borderline personality disorder or traits related to that, and whether there is something we call high expressed emotion or high criticism in the family, those are some indicators that you will have that an individual is at risk for not doing well in FBT. Now we're going to talk about each of those. And oddly enough, when we started, Judy said, how long is your presentation? I was like, well, I could talk for 5 minutes or 5 hours. So apparently I'm talking for 45 minutes and then there'll be times for questions. And if you feel like, oh my gosh, this is a lot of information, it is. I try to make sure that it's packed with all the things that you need, but you might want to go back through the slides later if you feel like you might have missed something, which is why I'm going to be sure that you have access to them. So for those of you who are having the feeling we've been trying FBT and it's not working, I want to first, again, before we start, because I'm a research scientist, like one of the things we know is you got to first make sure that you're getting the treatment as is. So if I said to you, the penicillin isn't working, I would first want to know, are you actually taking it as prescribed? Is the penicillin the right treatment that you got in the first place? So I'd want to make sure that there's not some other reason that we have more control over that you're not responding to that treatment. And likewise, I would consider making sure that you have an FBT expert first, because we know that not all treatment is created equal. I can't tell you the number of people I sit across who tell me, I got DBT treatment, I got FBT treatment. And as I ask more questions, it's clear to me that that treatment description is missing some really important factors, and the person believes they got the treatment but didn't actually. So for FBT to be effective, therapists need to be well trained and adhere to the core principles, including empowering parents, externalizing the eating disorder, and focusing on present behavior rather than solely on the causes. Okay, so first thing, if it's not working, check to make sure that you're getting treatment from an actual expert in the treatment. Now, there might be other reasons that the FBT is not enough or is not working, and we're going to look at those. And these are the things that cause the poorer outcomes. And they have, spoiler alert, they happen to be the same things that DBT is helpful for. So that's why Judy asked me to come. My background is I was an eating disorder psychologist first, and then later in my career, I learned DBT, and then in subsequently have been working in the last 25 years to merge the two models, merge the treatment of eating disorders with DBT. So just as an understanding of where that comes from. So we're going to talk about these things, and how do you know if this is something that might be the reason why your loved one is not responding to the treatment. So let's talk a little bit about, so what I'm going to do is I'm going to talk about when to consider DBT for someone who's got complex comorbid symptoms. And then we're going to talk about what DBT actually is. And then I'll talk to you a little bit about some models of merging the two together. So the first is whether, so this is the overview. If we see that, well, actually, you've already seen this slide in another form. This is just prettier and has more colors. And so we'll talk about each of them. So signs, so the one reason why you might consider adding DBT to an already existing FBT is that there are signs of an insufficient response to FBT. So if your loved one, and I say loved one because I understand that not everybody is an adolescent, not everybody is a child, not everybody is a young adult, and so I'm just going to use that term. And I've actually used an FBT-like approach even with adults who are living at home. So I'm just going to say loved one for ease of language. So if there hasn't been if there is a necessary weight gain because not everybody who has an eating disorder needs to gain weight, but if there was a needed weight gain and they have not gained 4 pounds in 4 weeks, we might say, this treatment might not be enough and we might need to add something. So weight gain is a necessary if they need to gain weight, but not sufficient indicator of progress. But another reason that we might consider adding DBT to an already existing FBT is that there is significant and chronic emotion dysregulation by either the patient or the caretaker. Now, again, I'm a psychologist, but I'm also a real person, right? So when I started putting this slide together, I'm like, so what is significant and chronic emotion dysregulation? Like, what does that mean to a regular person? Okay. That's where I got to that question. What is emotion dysregulation? What are we talking about? So we're talking about, so I went to Wikipedia because I think that's the easiest one. It's maybe not the most academic description, but I think it's had good plain language. Emotional dysregulation is characterized by an inability to flexibly respond to and manage emotional states, resulting in intense and prolonged emotional reactions that deviate from social norms, given the nature of the environmental stimuli encountered. Okay, so what the heck does that mean? I almost cussed, but I'm not going to. So that means to me, in plain English, it means responding or reacting to things that don't bother other people. It means responding more strongly than other people respond in a similar situation. And it means taking a longer time to come back to baseline after the situation has ended. Or you may see dangerous behaviors that are associated with emotion dysregulation. So someone gets very upset and they might engage in self-harm. They might engage in suicidal behavior or threats. They might engage in aggression and they might run away. So to me, so in DBT, so again, this is why I think it's very easy. It was very easy for me to get to, we want to add DBT to FBT when we have emotion dysregulation, because this is exactly what DBT does. It helps people who are more reactive, so they're more sensitive, so they respond to things that other people don't respond to. They have a more intense response and then a slower return to baseline. And usually they also have behaviors that other people perceive as problematic. They often perceive them as problematic as well, but for sure, people in the environment think that self-harm, suicidal behavior, aggression, and running away are problematic. And if you've done FBT and you have a kid who responds like this, that could make it very difficult to impose the treatment. I think the other thing I want to say, though, and this is where the issue about parental characteristics is important. If you are someone who has high reactivity, high sensitivity, high reactivity, and slow return to baseline, which again, you can without it being a problem. You just might be an intense person. You might be someone who's more sensitive than others. It can make implementing something like FBT very difficult, which is why DBT comes into play. But again, I'm not very good at the spoiler alerts because I already want to tell you everything and I'm not there yet. So the second factor or the third actually at this point, that we suggest you consider why we might consider adding DBT to an already existing FBT is when there is high expressed emotion in the family. So what is that? Family members with high expressed emotion are often hostile, very critical, and not tolerant of the patient. Again, this is a Wikipedia definition, okay? Now, again, let me finish and then I'll go back. They feel, and it's really important that you understand that we're not judging, but we might want to observe that often the family member feels like they're helping by having this attitude. Well, it must be that the patient doesn't quite get it, so I'm going to explain to them in a way that's has a lot of intensity, why what they're doing is a problem. They not only criticize behaviors relating to the disorder, but also other behaviors that are unique to the personality of the patient. High expressed emotion is more likely to cause a relapse than low expressed emotion. So again, if we're not judging the fact that this is true, and you probably know families like this, or maybe you are from a family like this, where it's common to be able to comment negatively. And the three dimensions of high expressed emotion are hostility, emotional over-involvement. So there's an interconnectedness between the patient's emotional life and the parent's emotional life, and then critical comments in general. Okay, again, these are some of the predictors of not doing well in FBT that DBT could help with. And then the final reason, I believe, to consider adding DBT to an already existing FBT is that there are comorbid symptoms that interfere with treatment. And we see this not infrequently, right? If someone's not getting better, it's often that there are other problems that are making the eating disorder treatment more complicated. So I see it when I see OCD, which is obsessive compulsive disorder. If someone has a comorbid obsessive compulsive disorder, they often have issues of foods being right or wrong, healthy or not healthy. That is kind of more than just your average eating disorder. And that gets in the way of the ability to follow through on eating more broadly. Having an ODD, which is when you have a kid that responds strongly to responses that exacerbate when limits are set. So these are kids who run away or become aggressive when limits are set, which is what happens in FBT. This can make the implementation of FBT more difficult. Social anxiety that makes eating in front of others more stressful. So it's not just that they are trying to not eat or have trouble managing their intake, but the social anxiety, the fear of what other people are thinking, make it more complicated. Depression that interferes with appetite. We know that in some depressions, people have less of an appetite, and in some depressions, people end up eating in a more binge eating sort of way. Those things can make it, again, more complicated. And finally, any neurodiversity that result in changes being difficult for the patient. When these things are on board, when there's more than one problem, it can make the implementation of FBT more difficult. And so we want to think about, is there something that we can add to it? Oh, and finally, obviously, suicide or self-harm. Um, we know that approximately a quarter to a third of people with an eating disorder have thoughts of suicide. And if we look at attempts, a quarter to a third of patients with anorexia or bulimia have made an actual attempted suicide. So it's not an uncommon thing for these things to run comorbid, and it makes it very difficult for parents to want to hold limits when they have a kid who has these sorts of experience, and understandably so, right? Which is why we might need to add something to the treatment. We also know that relative to others, their age and gender, those with anorexia are 18 times more likely to die by suicide. And with bulimia, it's 7 times more likely. So those fears that parents have are really warranted. It's not, if you're seeing this in your child, it's not a phase, or it may not be that they're trying to, because I've heard parents say these things, or manipulate you. We know that it's a real risk factor. Now, I will tell you though, because again, I am a researcher by heart. I don't do much research anymore. I'm more of a clinician and an administrator, and we do a little bit of research, but I always want to make sure I go back to the literature so that because I feel very responsible if I'm, as I'm giving a talk like this to people literally all over the world, that I say things that are based in fact, in research, not just based in my opinion. So I went back to the research, and as recently as 2023, there was a review that showed us that family-based treatment appears to take longer for adolescents that have comorbidities, and that on some level, we don't want to make a switch too quickly, but we do want to consider that we might want to add something when we have cases where people are not responding. Now I'm telling you that, and what I will tell you is, all right, well, then you're going to ask me, well, when should we add and when should we wait? And I don't know. There's not a lot of research for guidance, frankly. I'm not sure. But you need to talk to your team. And if your team is not skilled enough, you need to get a consultation. And as parents or as family members, I really want, I'm not done, but I'm just with this part of the conversation, I want to leave you with the notion of, don't stop asking questions. Don't stop asking questions of the people who are making decisions about your child's care, to be able to help you know, well, when are we sticking with, how are we deciding when are we sticking with this, and when are we deciding to make a change? So that to me is my background about what, start with FBT not working, who does it usually not work for, and then how do you decide what's next? So then in my mind, it always made sense to me to add DBT to treatment. And in my clinic, we add DBT to, if we have an adult, we're adding it to CBTE, which is usually the treatment that we start out with. So cognitive behavioral therapy for eating disorders for an adult. And with kids, we would start out with an FBT, and then we would add DBT. Now, why not just switch to DBT altogether? And I'm going to talk about what is DBT so you know what it is in a couple minutes, but I'm getting there, I promise. Now, when I started to think about, how we address these, the emotion regulation, the self-harm, the suicidality, the high expressed emotion, it didn't make sense to me to throw the baby out with the bathwater. We do have research to suggest that FBT is effective, and FBT has important components that can be effective. And my experience with families is, it's not that, oh, I'm doing the FBT as it's written and it's not helping. It's more that there's a lot of barriers involved because of the issues that I described to you. And so it made sense to me that we would add to it rather than switch completely. Now, I actually believe that DBT and FBT overlap. And so DBT has these assumptions of treatment that I think are very consistent with the premise of FBT. And the DBT assumptions help parents and the treatment team and the patient to be able to, I think, tolerate and manage the difficulty, because treating an eating disorder is brutal. It's brutal for most people. And the DBT assumptions really can help people to feel more confident and heard and seen. And I think they are consistent with what we learn in FBT as well. So first, people are doing the best they can. And when I say people, I mean the patients and the parents. Even if things are not going well, it's usually that they're doing the best they can and that they want to improve. I don't believe when people say, oh, she doesn't want to get better, he doesn't want to get better. I don't buy that. Nobody wants to have a miserable existence. They may not be able or feel as though it's in their power to make changes, which may look like they're not doing what they need to do. But most people want to improve. Also, if you think about that mentality, if you think, oh, they don't really want to improve, they don't care, you're not going to work harder for them. But if you think, yeah, they want to improve and there are barriers, we're all going to work harder. And I think that's important. People need, now, okay, people are doing the best they can in DBT. They want to improve and they need to do better, try harder, and be more motivated for change. So they might be doing the best they can and they have to do more. Because if they're not getting better, if the symptoms aren't changing, we all need to do more to be able to help this individual move to the next level. People may not have caused all their own problems and they have to solve them anyway. So you may have, sometimes families or kids will say, well, I'm like this because this happened to me or this happened in my family. It may be the case. And we have to help you solve your problems regardless of what got you there in the first place. The lives of emotionally distressed teenagers and their families are painful as they're currently being lived. We assume that this is very difficult and that teens and families must learn to practice new behaviors in all different situations in their lives. It's one of the things that struck me when Judy was giving the introduction, which was talking about the skills that are needed. Even if you are, this is a little aside, right? I believe that, especially moms, I'm sure this is true for dads to some degree, but I think that the fact that moms are biologically tied to their children, both from having carried them, but also the minute your baby pops out, your job is to feed them, right? We actually are physiologically capable of feeding our children from the first moments of their life, whether we choose to do that. But there's something hardwired in us to feed and take care of our kid. And when, fast forward, that they develop eating problems, even if you're not someone who is more emotionally vulnerable or has psychological issues that make it more complicated for you, it is really difficult to watch your kid either not eat or eat and get rid of it or be afraid of food. There's something really inherently difficult as a parent to watch that is going to be hard. And even if you don't need full DBT, which again, we're going to get to, I promise, you may need skills to be able to manage your own emotions in all situations of your life. And DBT can help with that. Okay, back to the list. There's no absolute truth. And teens and their families can't fail in DBT. This is back to that notion of what I showed you, that pill bottle of penicillin. We don't say, oh, you failed, you didn't get better. We say the penicillin failed you. So we say in DBT, the DBT might have failed you, not that you failed DBT. So what is DBT? For those of you who don't know, it is a treatment that blends acceptance and change. It is not just one versus another. And I will say that it is a treatment, and again, we're going to talk about it, that helps you to accept where your child is in this moment or where your loved one is in this very moment and help them to do things differently. It is not just change oriented. And this can be particularly useful and helpful for people that have these other comorbid problems where treatment does go a little bit slower. Now, there is a downside to adding DBT to FBT, okay, is that it's a lot of work and coordination to do both at the same time. And those of you who are on the call who have had experiences might want to, make a comment in the chat about your experience of this, because to do both of them simultaneously actually is a lot of work, but the alternatives are often problematic, and we'll get there. So the problem is that many standard DBT therapists are not trained or don't feel comfortable treating eating disorders. And that's another reason why we're not going to just say, oh, shift to DBT if you have these problems, because it is not uncommon for the eating disorder to be, I don't want to say ignored, but not addressed as readily. Now, so really, Lucine, you're saying 2 full treatments? So, and kind of I am. Now, both of the treatments get a little bit of a massage. I don't know that I'm going to have time to describe all of the ways that would be different than getting each treatment fully, but we are talking about doing a full dialectical behavior therapy treatment in addition to a full FBT. And we'll talk a little bit about what that means. Now, the truth is we also need more research. So those of you who are research oriented or looking for a project or, have a special interest in this, please do talk to your legislators. Please do talk to your the faculty members at the programs that you work with, because there's not a ton of research about, okay, so is it effective to add this treatment to that treatment? This is my clinical judgment and based in research, but it's not like we have a ton of outcome data. It's a little bit off label, so to speak. So let's talk about DBT finally. Okay, now I'm sorry it's so complicated, but I want you to know that there are different models of DBT that are out there. There is a DBT for binge eating or bulimia. So there's a very good treatment that was developed at Stanford by Deborah Safer and Christy Telch for binge eating or bulimia. But these are not people that we're describing. These are people who have just binge eating or bulimia and have emotion regulation as part of that picture. And that can be very helpful. But that's not what we're talking about, because we're talking about people with suicidality and self-harm. We're talking about people with comorbidity, but you may hear about DBT for binge eating or bulimia, and I want to make sure you understand it. There's also another DBT that's out there called RODBT, radically open DBT, which is a treatment that has been studied for use with people with anorexia, but does not address the eating at all. And it's a relatively new treatment, and it's, again, not what we're talking about, but just so you know. Then there's what we call med-DBT, which is multi-diagnostic eating disorder DBT. That is the adding FBT and doing FBT and DBT together. That's what I'm going to talk about. And then I want you to understand that there's something called standard comprehensive DBT, which is what, when you ask someone, are they getting DBT, that's usually what they're thinking about. And I'm going to talk about what goes into that. I'm sorry it's so complicated. As a field, we need to do better because it's confusing to professionals. I could only imagine what it's like for families. So now we'll tell you. So standard DBT, when I say standard comprehensive DBT, what I mean by that is DBT consists of 4 components that are necessary for it to be considered full comprehensive DBT. And that is an individual therapy by a DBT therapist, skills group and we're going to talk about these. And the skills group lasts 6 months or a year, depending on the age of the individual. Phone coaching availability, so the patient and the parents are able to call a coach outside of therapy sessions for help in crisis situations. And then all the members of the team that treat people using DBT have to be part of a consultation team that meets regularly, usually weekly, for 1.5 to 2 hours. So you can see that it's a big commitment. And I tell you that in advance of my next slide, which is, if you've been to residential or a higher level of care, you've likely been exposed to DBT skills, because let me tell you, DBT skills are super useful. I taught them to my children. There's actually, which, maybe we should talk about at a later date, and then there's actually a model of DBT where the skills are taught in schools, not to even kids with emotional problems, but as a general education way to teach kids about managing emotions. It's a phenomenal set of skills. That being said, if you have been exposed to DBT skills in a higher level of care, this does not mean that you receive the full treatment. Because sometimes I sit across from people who will say, well, we already got DBT. We were in residential. I was in residential for a month. I did DBT skills twice a week for a month. That's not the full model. You might have been exposed to the skills. You might have even learned the skills, but it's not the whole shebang. Okay, so what is the structure of standard DBT? I told you. Now, I think what's important to know as a family member, because it is, just because of who F.E.A.S.T is and who I'm assuming is sitting here today, listening to my talk, is that you're probably wondering about where do you fit in, right? So in DBT for adolescents, because there's a DBT for adults, like full up adults. I don't know how I'm differentiating that, but there's a DBT for people who are not living at home, and then there's a DBT for adolescents and children. And in that, those people are in a weekly individual psychotherapy. However, there is family involvement in those sessions. And there are ways, especially when there is conflict at home and the conflict is part of what is problematic for the kid managing their own emotions, or that the parents need something to happen, they are brought into the individual psychotherapy, but it's not, because I think that there's a lot of models where your loved one is in an individual therapy and they go in and the door is shut and you never hear anything about it and you're not invited in. That's decidedly not what happens in DBT. And so I think that's important to acknowledge. And then there is a group skills training. Now, the way this works with adolescent DBT is that the kid learns the skills and the rest of the family learns the skills. And in some models, those kids and family members are in separate groups, but in the way that it was written through research and the way that we do it at our clinic is that parents and kids are in the room together with other parents and kids who are learning the skills together. Because if you think about the fact that your child or your loved one needs to learn skills to manage their emotions better, if you learn them in isolation, even if you're not, okay, so as a parent, I'm here to tell you that we give our kids genetically our good stuff and our bad stuff. As far as I know, there's no way to control it. And if your kid has emotion regulation difficulties, it's likely that they inherited it from somebody else in the family and with no judgment associated with it. And so it is likely the case that the parents or the family members need to learn those skills as well. And even if you're not somebody who has those sorts of reactions, the DBT skills are useful to be able to help. So parents and kids are in the skills group together. Telephone skills coaching, as I said, both patient and parents have access to a skills coach and then the team consultation. So let's talk a little bit about what is the goal of individual therapy in DBT: to reduce life-threatening behaviors. Now that might be suicide or self-harm, but it could also be the eating disorder when the eating disorder is so severe that it is putting your loved one at risk. To decrease therapy interfering behaviors, to decrease behaviors that get in the way of treatment, missing treatment, showing up late to treatment, not doing your homework, not following through, angry outbursts, those sorts of things get addressed directly in DBT treatment in the individual therapy. The goal is to improve general functioning, build a life worth living, especially without an eating disorder. Like, how are you going to have a life without your eating disorder as something that you rely on as part of your identity? It helps, the individual therapy helps to apply the DBT skills. So you learn the skills in the group, and then in your individual therapy, you talk about how you're implementing them. It helps enhance motivation, which is basically keeping people in treatment, because you can't get better from a treatment that you don't get the full treatment for. So we want to help keep people in treatment. That happens in the individual therapy. It works to address underlying issues and to develop a strong therapeutic relationship. So that's the goal of the individual therapy. The weekly skills group, as I said, parents and kids, 90 to 120-minute group that happens weekly. It's run more like a class than a process group. So it's not like, let's talk about our feelings. It's more like, okay, here's a skill. Well, actually, it's what was your homework for last week? How did you practice the skill we learned last week? Here's your new skill. And then here's your homework for the new skill. So if those of you who are listening are not familiar with DBT, I think sometimes the skills group can feel a little daunting because you think, oh my gosh, what, are we going to have to bare our souls? No, not really. You have to learn the skills and learn how to practice them, and that's what's done in the group. There are 4 or 5 modules, and I'll show you that in the next slide. At least one parent is included, and it's a 6-month or 1-year commitment to the skills. And I think that's important also to remember, because part of the deal here is that it takes a long time. This is not a quick fix. So just so you know, the skills, these are the 2 different skills group manuals that a patient might have. On the left is the skills group for the skills training handouts for adults, and on the right is for adolescents. And each of them includes, well, I'll just tell you. So the ones that I'm going to review first are common to both the adolescent and the adult skills, and then there is one skill that's specific to the adolescent groups. So there are 4 modules in each of them, and they are directly developed to address problems that we see with people with emotion regulation difficulties. So core mindfulness skills are taught in DBT, and they help to treat confusion about yourself as well as focus problems. Like, do you even know what you're feeling? Do you know what's going through your mind? It's hard to change things if you can't actually notice them and articulate them. Then there's what we call interpersonal effectiveness skills. And these, as they sound, are designed to help people with interpersonal problems. How do you get what you want without severing the relationship? How do you assert yourself in a way that is fair to you and fair to the other person? Emotion regulation skills are designed to help you identify your emotions in conjunction with the mindfulness skills, and then understand, are these things that I should act on or I should wait? How do I understand what I'm feeling and be able to act on it appropriately? That's the emotion regulation skills. And then which is very actually relevant for people with eating disorders, because as we well know, not eating adequately makes us more vulnerable to having intense emotions. So it's actually one of the skills in DBT, in the emotion regulation skills. And then there's distress tolerance skills, which are designed to help people have emotions and not act impulsively. And so those are common to both the adult and the adolescent modules. And then in the adolescent specific, there is something called walking the middle path skills, which are designed to teach teenagers and families how to deal with particular challenges that they have that are unique to that dynamic. So not thinking dialectically, kind of black and white thinking, invalidation on either end, and poor contingency management, meaning, parents not being able to hold limits. And that is addressed in the walking the middle path skills. So these are the skills that are learned in DBT in the skills group that are then reinforced in the individual therapy, but then they are also something that happens. Yeah, okay, then let me tell you this first. So obviously, I don't know about you, but have actually 100% have had this experience. Don't think just because I'm a psychologist, I'm not. I'm human also. I've had a couple moments like that with a child of mine, and so we need to learn skills too. And in FBT, in DBT, we use DBT language and skills without compromising the FBT by helping kids to tolerate versus negotiate around food, and using their interpersonal effectiveness skills with parents without trying to change the way that they feed you. Now, part of the deal is then there is using those skills in real life, and that's where the telephone consultation comes in. You have skills coaching in the moment for things like, are you eating or not eating? Are you self-harming, angry outbursts? The patient and the parents can call a separate clinician. They don't call the same clinician. The kid calls their individual therapist, and the parent calls their skills group leader to say, okay, how do I use my skills in the moment in this situation, which is invaluable. And then there's consultation team, where if you think about it, it is baked into the treatment that we are meant to meet regularly, do the treatment as it's written, be more skillful ourselves, and support each other so that we don't burn out and we are the best therapists for you and your family. I will say that, because in the service of time, and again, you'll have these slides, DBT will help because it allows us to take all the problems that your child has and put it into this hierarchy where we start at the things that are life-threatening, and then work on things that are therapy interfering, and then work on things that are just getting in the way of life. And we do this by the base of the whole treatment is learning skills. And this is both in each individual therapy session and across the treatment. So there's a couple different ways that FBT and DBT can be merged. And that the first one is just doing the whole model, doing both of them. There's individual treatment, multifamily skills group, phone coaching, consultation team, and full FBT. That's doing both, and that's one model. Another model is doing parent-focused FBT plus DBT. And I will say, listen, if you're thinking, okay, but FBT isn't working for me, what we do is we help parents when using DBT to find a way to be able to stay involved in their child's refeeding in a way that makes sense for the whole family unit. And so it may look a little bit different than standard FBT, we're going to sit at the table for 5 hours until you eat sort of thing, but it does keep parents engaged and part of your child's ongoing treatment plan. So parent focused, where it's just it's full DBT plus instead of an FBT where the parents and the kid are meeting with an FBT therapist, the parents are only meeting with an FBT therapist, which sometimes can help if you have a kid that has pretty strong emotion dysregulation. And then finally, if you have an adult child where it does not make sense for the adult to be getting FBT, we often have like full standard DBT plus CBTE. And that is done with one person. We're not really talking about that today, but I did want to make sure that you understood that was also a possibility. And if that was something that you thought you wanted or needed, you have to make sure that the individual therapist is comfortable and has experience treating eating disorders. So these are the different models of using an empirically founded, evidence-based intervention for eating disorders plus DBT, and this DBT plus CBT for eating disorders is part of it. So I wanted you to know that it existed, even though that wasn't exactly the point of my talk. So how do you find a DBT therapist? I have given you a link here. That is the DBT Linehan Board of Certification. That's one way to find a certified clinician in DBT if you're interested. And I've given you a list of questions to ask. How are you trained in DBT? Because just like in FBT, if you have someone who's not fully trained, they're not going to give you the full model. Do you offer phone coaching, which is something that people will say they do DBT, but don't offer it, and that makes me crazy, but that's another conversation. Are you part of a consultation team? Again, if you don't do either of those, you're not really doing DBT. What is your comfort level for working with someone with an eating disorder? How many patients with an eating disorder have you treated? What's your training in eating disorders? Are you willing to get consultation from an eating disorder expert to treat my loved one? Because that's the other thing I find. You might live in a place where it's not that person may not have, this is the only person you have availability to, but they can get more consultation from someone who knows the model and coach the therapist in terms of giving you what you need. And I think the other piece is don't give up. Like, your loved one can get better. Keep asking questions, keep fighting for what you believe they need, and keep having discussions, because unfortunately, it can feel like you're fighting uphill. So I'll pause there and I will stop sharing my screen and open for questions.
Thank you.
Yeah.
That was a lot of information.
I'm sorry. I know it was, but I couldn't figure out how to make it shorter.
No, it's great. The more information, the better. It's just a lot to process.
Yeah.
You had referenced early on in the presentation, early onset. What do you consider early onset?
That's a good question. I don't know if I'm sure there is a research definition of early onset, but it's meaning your kid develops an eating disorder earlier in life. So probably earlier than age 17 is going to be my guess. But I
Okay,
don't quote me on that because I think that's a research definition, not a Lucene definition.
okay. Um, and I see some questions really about, that MED DBT is at this point, really hard to find. So I kind of see some questions about like how do different DBT groups, how are they different than RODBT? And I think, the questions that I'm absorbing here is, you know, is some DBT better than no DBT? Are there different types of DBT that might be suitable if you can't find the MED, DBT?
Yep.
Like what, in other words,
Yep.
to the parents who are really not going to be able to find what you just recommended,
Right.
in short, what do they do?
Yeah. I think that what I would suggest in that um, scenario is that and we're going to think dialectically. So that, that's the first word in DBT is dialectical behavior therapy, which means that two things can be true at the same time that seem like they're in opposition to each other. And so if you can't find someone to give you the full model, I think it is not unreasonable to think about adding DBT skills to what you're already doing. Because as I said to you earlier, DBT skills in and of themselves are useful tools for us to know how to manage our emotions better, to help our kid manage their emotions better. So it's a little bit like, they say put your oxygen mask on when you're on a plane if something happens so that you can take care of your loved one. If you learn to take care of your emotions better, then you will be a better role model, provider, advocate for your kid. Now, the thing that you have, this is the dialectic. The thing that you have to be aware of is to not then be lulled into the belief that, well, I got the DBT and it didn't help me. Because having the skills is a useful piece, but it's not sufficient to be able to get the DBT. Because what DBT in and of itself offers you is sort of a different way of thinking about the illness and a different way of approaching the illness, which is more than just the skills. So if you can't get the whole package, by all means, get yourself into a skills group. It's not going to hurt anybody. The only thing that would hurt is when you think, well, I had DBT and it didn't help me. Does that make sense, Judy?
Yes, it does make sense. Thank you.
Yeah.
If a family is doing the full DBT and FBT, what is addressed in the FBT sessions? And is the DBT individual therapist considered the quarterback? It's kind of an interesting question.
Love that question.
Who's driving? Exactly.
Yeah, love that question. Yeah. So in my mind, the quarterback is actually I guess it depends on what the problem is. And so what happens in the FBT sessions is the parents are trying to figure out how to continue to refeed their kid in a way that makes sense given the multiple comorbidities and the multiple problems. And so it generally does, as I said earlier, it doesn't look like just standard FBT. It's not, you're not going to sit at the table. You might sit at the table for 4 hours until your kid eats, but it's trying to find a way to be more flexible while still understanding, and this is the way we even talk about it with the kids who will be in an individual DBT therapy. Listen, when you can take responsibility and act responsibly about your food, you can have responsibility back. But until then, we can't take that risk, and your parents need to be involved in making sure that you're eating adequately to make sure that you're getting the nutrition that you need and not messing with your food. And when you can do that yourself, well, we won't need your parents as much. But until you can do that, parents will still ultimately be the buck stopper around your eating. And so it's a dialectic. So now the question about who is the quarterback, I think really depends on what the whole team looks like. Because unfortunately, because as people are saying, like it's hard to find this treatment. The treatment manual is coming out at the end of the year. So that's going to help a lot. But in the meantime, you know, you might be in a DBT therapy at this clinic and your FBT is in that clinic, and it makes it very difficult. And those people have to talk within themselves about whose role is to do what, and whose role, what is the quarterback, you know, who is ultimately the buck stopper for the whole treatment is going to really depend on clinic by clinic, I think.
Thank you.
Yeah.
Okay, unfortunately, we are toward the end of this webinar. I hope that, you know, in a way I understand that it's kind of frustrating, because you learn about this amazing treatment and it makes so much sense on so many different levels, and it's not available to so many parents. And that being said, I still think it's really important that we know about all the treatments out there, and that we, you know, do our best to find the good ones to the best of our ability, and just we really understand it because it makes so much sense. You know, I know so many families who think that they failed FBT. They didn't fail FBT. They needed DBT. There was comorbidity. There are a lot of different issues, emotional dysregulation, and FBT just isn't enough. So I really want to frame it as FBT not being enough. For some families, it is, but for those families who it's not, it's really amazing to know that there is a new treatment being developed that has a lot of potential to do good in the future, if not now, as soon as it's more readily available. And, you know, I thank you, Lucine, for, you know, really being a pioneer in this. And, you know, we can't get most therapists to either be DBT or FBT, and you're both. So, you know, that's really a credit to how much you want to help people.
Thank you.
So thank you so much for being with us. I just want to mention that all of our programs and services are enabled by the generosity of people in our community. So if you benefited from today's webinar and you got something out of it and you'd like to give back to F.E.A.S.T, you can go to our website and donate. We'd really appreciate it. And our next webinar, actually before the next webinar, I just want to put in a plug for our social media. We have amazing social media. It's really underutilized. So find us on Facebook, find us on LinkedIn, find us on Instagram, and follow us. And then you'll never miss an event, or there's a lot happening in F.E.A.S.T, and stay connected. And now our next webinar is going to be really interesting. It's Dr. Leslie Williams talking about medicines like Ozempic in the context of eating disorders. It's a topic that I've heard discussed in parent and professional communities. I've heard Dr. Williams present about this topic. She's amazing. And join us, please, on September 17th for that webinar. So again, thank you all so much for joining us. Thank you again, Lucine, and have a good day or evening, everyone.